Hello and welcome to Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm a professor of medicine and an interventional cardiologist at the University of Chicago. I also serve as an associate editor for JSCAI, and it's in that capacity that I'm honored to represent SCAI. And on behalf of Dr. Alexandra Lansky, editor-in-chief of JSCAI, I will serve as the moderator for this discussion. We're here today to discuss a very important document published in JSCAI titled the SCAI, EAPCI, ACVC Expert Consensus Statement on Cardiogenic Shock in Women. I'm joined by an esteemed panel of SCAI leaders and experts. The presenting authors, Dr. Suzanne Barron, who's the Director of Interventional Cardiology Research at Massachusetts General Hospital in Boston, Massachusetts. Welcome, Suzanne. Our panelists include Dr. Babar Basir, Director of the STEMI program and the Acute Mechanical Circulatory Support program at Henry Ford Health System. Welcome, Babar. Good to see you again. And last but certainly not least, we're joined by Dr. Mirvat Alasnag, Director of the Cardiac Catheterization Laboratory at King Fahad Armed Forces Hospital in Jeddah, Saudi Arabia. Welcome, Mirvat. Thank you all so much for taking the time to join, and now I'm going to turn it over to Dr. Barron to start the conversation.
Great. Thanks so much, Sandeep. It's my honor to present on the SCAI Expert Consensus Statement on Cardiogenic Shock in Women. This is the list of authors who are involved in this, and certainly want to give a shout out to Dr. Alexandra Lansky and my co-chair, Dr. Josephine Chow, for leading this important effort. So just to start off with a little bit about what the rationale was for writing this expert consensus document, we know that while cardiovascular disease-related mortality rates have decreased over the last 2 decades, the rates for in-hospital mortality and longer-term mortality for cardiogenic shock haven't changed, and they remain pretty high. Current evidence suggests that there are significant sex-based disparities in the timely delivery of optimal treatment for cardiogenic shock in women, and then this subsequently contributes to persistent poor outcomes. Not only do women encounter delays in treatment, but they're less likely to receive guideline-recommended coronary interventions or device therapies when compared with men, and that's independent of disease severity. Our current society practice guidelines don't have sex-specific recommendations, and they also don't highlight the instances where evidence regarding the diagnosis or treatment is insufficient to optimize outcomes in women. And so this consensus statement really aimed to provide a comprehensive summary of the available evidence on cardiogenic shock in women, to identify knowledge gaps, and then suggest directions for future clinical investigation. So with regards to methodology, the writing group was organized to include a diverse geographical perspective as well as a diversity of specialties, including heart failure, interventional cardiology, cardioobstetrics, and critical care cardiology. The statement was done and written in collaboration with the European Association of Percutaneous Cardiovascular Interventions, as well as the Association of Acute Cardiovascular Care. And the consensus tips were discussed and voted on by the full writing committee, and consensus was defined as 75% or greater an agreement. The statement begins with a review of sex-based differences of the etiology and presentation of cardiogenic shock. We know that there are certain etiologies of cardiogenic shock that are more common in women, including SCAD, Takotsubo's, myocarditis when compared to men. And certainly hormonal differences can account for some of these observed differences in etiology and presentation. Estrogen has a known anti-inflammatory effect that can protect against cardiac cell death, oxidative damage from ischemic reperfusion injury, endothelial dysfunction, and adverse cardiac remodeling. But these hormonal differences may have paradoxical harmful effects by decreasing ischemic preconditioning in women compared to men. And beyond the different underlying shock etiologies, the clinical presentations of shock differ based on sex. Women tend to present with higher LVEF or similar and even lower rates of renal or liver insufficiency. However, hemodynamic studies have shown that women with shock have lower cardiac index or lower cardiac power output, and so this often will lead to women being mischaracterized as being clinically stable, despite the fact that they're having ongoing systemic hypoperfusion, and that can lead to delays in the initiation of appropriate advanced care. The document's broken into sections dedicated to reviewing the diagnosis and management of specific types of cardiogenic shock in women. We've included sections on acute myocardial infarction, heart failure, valvular heart disease, and then cardiogenic shock in the pregnant and postpartum patient. Each section reviews the available sex-specific data for diagnosis and treatment, with specific highlighted consensus tips on topics such as the role of mechanical circulatory support, and then also areas where there are significant evidence gaps. While cardiogenic shock is rare in pregnancy, it's associated with high rates of maternal and fetal mortality. And we know that peripartum cardiomyopathy is the most common case of shock related to pregnancy. Care of the pregnant patient, obviously, it's an important thing for women, and it poses unique challenges because there's a focus on caring for both the mother and the fetus. This can affect medication choices, use of mechanical circulatory support, procedural access and positioning, and radiation exposure. Given the complexity of these patients, a multidisciplinary team collaboration among cardiology, obstetrics, anesthesiology, critical care, and neonatology, it's paramount to maternal and fetal safety. And these considerations are shown here in this figure, highlighting the pillars of therapy when managing cardiogenic shock in pregnancy. The SCAI shock classification, initially released in 2019 and updated in 2021, provided the cardiology community with a 3-axis model that integrates shock severity, clinical phenotype, and risk modifiers across both men and women. And so what we did in this document was build upon the SCAI shock classification to provide a consensus on best evidence-based practice pathways of care to optimize early diagnosis, early monitoring, the treatment of women with cardiogenic shock, and that's what's shown here in our central figure. Clearly our work isn't done, though. There are many barriers to care in women with cardiogenic shock. Studies have shown that concern for bleeding or vascular complications in women can deter the use of temporary mechanical support, despite demonstrated improvement in complication rates in both men and women over time with techniques that optimize large bore access. And while we know that data in cardiogenic shock is limited for everyone because it's difficult to study this disease state, there's a striking dearth of sex-specific data. And that's in part driven by what you can see here. With this figure, you can see that the major cardiogenic shock trials and the percentage of women who comprise those study populations, in most trials, women don't even comprise 30% of the study population. So without improved enrollment, it's going to be hard to really understand the risks and benefits of existing and novel treatments in women with shock. So in conclusion, then, early identification of cardiogenic shock and its etiology and early referral for mechanical circulatory support is paramount to improving mortality outcomes in women. And we hope that a standardized approach to diagnosis and treatment, as detailed in our central figure, may help to reduce sex-based disparities. We need better representation of women in shock trials, and we should be considering dedicated RCTs of women with shock to determine the best treatment strategies to improve outcomes. We hope that this consensus document provides a comprehensive summary of the current state of treatment in cardiogenic shock in women, and that it can be widely used as a resource to guide clinical practice and ultimately improve the care of our female patients. Thank you.
Thanks, Suzanne. That was a fantastic overview of a very comprehensive paper, which I think everyone invested in the shock space should read a couple of times. Maybe I'll take the prerogative of moderator and ask the first question. How do you think readers should frame the differences between men and women as it relates specifically to etiology of shock? Meaning, should we have sort of closer eyes and surveillance on women with known LV dysfunction who are just sort of admitted to the floor, hospital service, tele service with with decompensated heart failure, when in fact they may actually be in cardiogenic shock? So, how do you think we should be thinking about this as it relates to etiology?
I think while, atherosclerotic and acute MI-related cardiogenic shock is the most common etiology of shock for both men and women, there are certain things within that we aren't necessarily are more common in women, like SCAD, particularly is one of them, as well as Minoca as well, can also and eventually contribute into shock as being it's sort of on the spectrum of heart failure, as well as atherosclerotic disease. A lot of the times, because women are presenting with less hemodynamic instability, or perceived less hemodynamic instability, it can be easy to overlook this. So I do think that having a very standardized way of approaching patients with, serial monitoring of lactate, considering early use of PA lines to really understand what patients' contractility and cardiac power output is really important. It's important for men and women, and so I really do think having some but women are often overlooked, and so I do think that having a standardized approach can be something that would really help.
Mirvat or Barbara, would you like to add to that? Mirvat, you bring a distinctly international perspective to this. How does this sort of resonate in the Middle East and Europe and Asia?
It's interesting. This is a joint document from Europe and the US, but a lot of the findings and then the recommendations are really very universal. They can be seen everywhere, that there is paucity of data across the globe. There are late presenters. And what makes it difficult is the underlying etiology, as you sort of mentioned, Sandeep, that, it could be pregnancy related, so peripartum cardiomyopathy, it could be Takotsubo, SCAD, but then it could also be, acute MI related. So the etiologies are very different, the outcomes are very different. But one thing that is very clear is the presentation is very often late. And, the uptake of mechanical support and very aggressive circulatory support in general, and applying algorithms is not as it should be or where it should be.
Barbara, should we be adopting differential approaches for risk stratifying men versus women, as we do in other aspects of medicine in general? But I mean, should we be sort of incorporating this as a risk modifier? Or is that premature? What do you think?
Yeah, I think that the driving force of women having worse outcomes goes to what Dr. Barron and Dr. Anastagog said, which was that ultimately these patients aren't being recognized and treated early. So within the shock initiative, we presented data last year at CRT that demonstrated that when people were treated with a shock protocol for AMI cardiogenic shock, both men and women had similar outcomes. And that was defined, though, by actually getting the therapy and getting the therapy at a reasonable time. When we go back to the DanGer shock trial and we look at the sub-study of women that were included within that trial, which was an all STEMI trial, so there's not NSTEMI included, one of the driving forces for women having poorer outcomes was the fact that there was a delay in the treatment. And so I think what's really important for our community to establish is the fact that we have to have more vigilance in making sure that we're identifying patients, women in cardiogenic shock at the same level that we are with men, and that we're offering them the treatments that are known to benefit all patients early on in their course.
Well, I think that's a great point. Suzanne, you touched upon misclassification bias, or women being overlooked, the sort of perception of clinical stability when in fact they're not actually stable. How do we fix that? I mean, hemodynamics, I think, is sort of paramount importance and underutilized across sexes, but how do we sort of fix that?
I think it goes back, actually, echoing a lot of what Barbara just said, which is that I think standardized protocols really can help, particularly in those early phases. And that is something we do talk about in the consensus document, where we do recommend, for any concern of a patient presenting with a woman presenting and men presenting with a cardiac issue, early serial monitoring of lactates, early consideration of a PA line for diagnosis, not necessarily that's needed for tailored treatment, but for diagnosis. With that sort of kind of standardized approach, as Barbara said, we hopefully can at least decrease some of the sex-specific differences. I think it's also going to be important to understand some of the etiologies that are more common in women a little bit better. So, the ongoing research into SCAD and SCAD-associated cardiogenic shock, I think that's going to be important. Certainly, pregnancy and peripartum related cardiomyopathy. These are very difficult populations to study for obviously a myriad of reasons. But I think it is imperative that we do kind of think about how we can dedicate and really focus some of our research efforts on these really understudied areas.
Great points, all. I have one final question, and you touched upon this in your conclusion slide about separate trial data in women. We're at sort of a tipping point for mechanical circulatory support, I feel, after the publication of DanGer and the long-term follow-up and so forth, and with a number of very promising devices in the investigational pipeline. I feel like we're poised for, sex-specific trials, or at least trial enrollment quotas. What are your thoughts about that?
So I absolutely agree with that. I think there, Dr. Lansky, our editor-in-chief of JSCAI, led a really important all-female study called the Empower CAD study, looking at the treatment of calcified lesions just in women. And, she'll often say this, that the trial enrolled much faster than they expected. So it really wasn't a question of that these patients aren't out there. They are here, and it is a doable thing. I think that's one of the concerns. If you say, well, if we just limit to just women, is the trial going to go on for a long time? Are we not going to be able to enroll? I don't necessarily think that that's the case. I think that women are out there. We just have to focus on it. And I think with that, we will be able to get some more data. So I agree with you. I think we are very much poised to say that there need to either be set quotas, including women, as well as underrepresented minorities, or even considering, just an all-women trial, or even just registry of cardiogenic shock patients.
And Suzanne, it's really nice that your publication came out at this time, because we're on the stepping stones of many trials being formulated, particularly for high-risk PCI and small bore hemodynamic support devices. And so I think it's really important for us to outline to the community that it is an expectation that they significantly have a large portion of women within these trials, so that we can better understand if these small bore devices are safer and better, particularly for women as compared to men.
Mirvat, any final thoughts?
There is, hope for the future for women who present with cardiogenic shock. I think the community is finally enthusiastic about really exploring areas. Some of them we just mentioned, like vascular access. We know that bleeding and vascular access are probably the leading causes of cardiovascular morbidity and mortality in these women. But we also want to start looking at different areas, like postpartum women who have postpartum cardiomyopathy. They may need mechanical support for longer duration. So we may need to be studying things like that, like access site, alternate access for devices, and how safe it is to keep these devices in subclavian or what have you, and start these rehab programs. So there's really a lot of exciting areas that we could be looking at, and I think we're finally having these conversations, and really, really proud to be with this fine group of investigators to look into it.
Wonderful. Suzanne, congratulations to you and all the co-authors on a fantastic paper, and thank you all for joining us today. We'll conclude there. Thanks so much.